Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing a very important topic in the cardiology, that is the dilated cardiomyopathy. So, dilated cardiomyopathy, as the name itself tells you, that the chambers within the heart, they are dilated more than normal. And the very important point about this dilated cardiomyopathy is that it is the disorder which is characterized by heart failure with reduced ejection fraction. So in these individuals, the ejection fraction will be less than or equal to 40%, and along with that, all the chambers within the heart, they are dilated, right? And it is the disorder where you have predominantly systolic dysfunction, which is much more prominent, right? Systolic dysfunction, much more prominent than compared to that of the diastolic dysfunction. Whereas you take the other forms of the cardiomyopathies. In case of the hypertrophic cardiomyopathy or in case of restrictive cardiomyopathy, it is predominantly diastolic dysfunction. But whereas dilated cardiomyopathy, it is predominantly the systolic dysfunction. And remember, this dilated cardiomyopathy, it is the most common cause of all the forms of cardiomyopathies. Whereas the rarest form of cardiomyopathy is the restrictive cardiomyopathy. Now, what are all the various etiologies? There are multiple etiologies which will cause the dilated cardiomyopathy. One among that is the myocarditis. And this myocarditis, it could be either infective or the non-infective causes. So the infective and as well as non-infective causes of myocarditis causing dilated cardiomyopathy, I have discussed separately in a separate section of a topic called myocarditis. So you can go through that section for the infective and as well as non-infective causes for myocarditis. And then we have toxins and as well as the drugs. What is the most common toxin that will be causing the dilated cardiomyopathy is the alcohol, right? So excessive consumption of the alcohol daily can make the individual to develop dilated cardiomyopathy, or the binge alcohol consumption will make the individual to develop what is called as the holiday heart syndrome, which is nothing but where the patient will develop atrial fibrillation. And there are many other chemotherapeutic drugs which will be causing the dilated cardiomyopathy. So even the toxins and as well as drugs causing myocarditis, I have discussed that in a separate section. You can go through that. Now, the very important is the metabolic causes. So we have metabolic causes, familial, some overlap conditions, and some miscellaneous causes for the development of dilated cardiomyopathy. Now, let me tell you, so these are all your inflammatory conditions causing myocarditis, that is your both infective and as well as non-infective. And among the infective, what you have to remember very importantly is the viral infections. So it is mainly your Coxsackie virus and as well as the ecovirus. They are the very important viruses that will be causing myocarditis. And then parasitic infections, right? The parasitic infections like Trypanosoma cruzi, that is one of the very important parasite that can cause myocarditis and make the individual to develop dilated cardiomyopathy. Bacterial infections, spirochetes, rickettsial, and fungal infections. These are the infectious pathologies which will cause myocarditis and subsequently will make the individual to develop dilated cardiomyopathy. And non-infective causes, that they are mainly the granulomatous diseases like sarcoidosis or giant cell myocarditis, polymyositis, dermatomyositis, transplant rejection, and checkpoint inhibitor chemotherapy. These are the non-infective causes which will be causing myocarditis. So this entire section of the infective and non-infective causes for myocarditis, we have discussed this completely a separate topic, right? And yes, now let me tell you about the metabolic causes. So among this, the first important is the nutritional deficiencies. So what are the nutritional deficiencies that can cause the dilated cardiomyopathy is the thiamine deficiency, which is nothing but your B1 deficiency. And then another important mineral, that is selenium deficiency, can cause the dilated cardiomyopathy. And then the carnitine deficiency can cause the dilated cardiomyopathy. So these are the nutritional deficiencies which can predispose to dilated cardiomyopathy, and I will discuss these nutritional deficiencies in detail subsequently. Now, what are the electrolyte deficiencies? The electrolyte deficiencies, very important, is the calcium deficiency. So calcium is very important electrolyte which is required for excitation contraction coupling, and the deficiency of this can cause dilated cardiomyopathy. And the other deficiencies are the magnesium deficiency and the next is the phosphate deficiency. So these are the electrolyte deficiencies which can make the individual to develop dilated cardiomyopathy. Next is the endocrine disorders. Among the endocrine disorders, let me tell you the thyroid disorders, both your hypothyroidism and as well as the hyperthyroidism, both of that will predispose to the thyroid disorders. So both hypo and as well as hyperthyroidism can make the individual to develop the dilated cardiomyopathy. And next important is the diabetes mellitus. Next is pheochromocytoma, that can also make the individual to develop dilated cardiomyopathy. And next very important risk factor is the obesity. So obesity, because of the fluid overload, I'll be discussing this in detail again. Because of the fluid overload, there will be stretch of the myocardial tissue and makes the individual to develop dilated cardiomyopathy. And next is the another important metabolic abnormality is the hemochromatosis. So hemochromatosis is a condition which is characterized by excessive accumulation of the iron within the cardiac myocytes. Now, this excessive accumulation of iron within the cardiac myocytes will make the individual to develop dilated cardiomyopathy and as well as the restrictive cardiomyopathy. Right, we make the individual to develop dilated cardiomyopathy as well as the restrictive cardiomyopathy. Now, let me take up the individual nutritional deficiencies which can cause the dilated cardiomyopathy. So, one is the carnitine deficiency. So, this carnitine deficiency will not only make the individual to develop dilated cardiomyopathy, the individual will also develop restrictive cardiomyopathy as well because of the carnitine deficiency. And this carnitine deficiency, it is very commonly seen in the children. And what exactly is the carnitine? See, carnitine, it is essential cofactor which is required for long chain fatty acid metabolism. Right? It is an essential cofactor which is required for the long chain fatty acid metabolism. Now, if there is carnitine deficiency, what will happen? That will lead to intracellular lipid accumulation. Right? That will lead to intracellular lipid accumulation within the cardiac myocytes. And where there can be stretch of the cardiac myocyte, and that will make the individual to develop the dilated cardiomyopathy or the excessive accumulation of the intracellular lipid inclusions that can make the individual to develop even the restrictive cardiomyopathy as well. So basically, the fatty acid oxidation that requires multiple steps with specific enzymes. So once there is a carnitine deficiency, the enzymes which are required for the fatty acid oxidation, they get defective, and thereby there is impairment of the fatty acid oxidation resulting in the intracellular lipid accumulation. Right? Now, depending upon the defect, so what you can do is either you supplement carnitine, right? Either you supplement the carnitine or you need to replace fatty acid intermediates. Right? You need to replace the carnitine, or you need to supplement the carnitine, or you need to replace the fatty acid intermediates. So once you do this, then the cardiac and as well as the skeletal myopathy can be reduced. Okay, so the cardiac myopathy can be reduced. So that is about your carnitine deficiency. And the next important is the selenium deficiency. So deficiency of the trace element, that is selenium, can cause cardiomyopathy, and that we call it as the Keshan disease. Right? That we call it as the Keshan disease. Now, a very important virus is associated with the development of this Keshan disease. Now, what is that virus? So, the selenium deficiency along with the Coxsackie virus infection. Right? Along with Coxsackie virus infection, that can lead to the Keshan disease, which is significantly fatal. That is significantly fatal. Now, what will be the clinical features in these Keshan's disease? Once the individual develops dilated cardiomyopathy, there can be decrease in the cardiac output, right? There can be decrease in cardiac output. So, there can be mild to severe form of, right, mild to severe form of the selenium deficiency. And in these individuals, because of dilated cardiomyopathy, there can be decrease in the cardiac output that will result in fatigue. Okay, because once the perfusion to the organs reduces, there will be fatigue, and because of the heart failure with reduced ejection fraction, there can be pulmonary edema, and because of which the patient can develop dyspnea. Right, dyspnea is another important clinical feature, right? And these patients, they can also develop chest pain because of decreased myocardial perfusion. And this dilated cardiomyopathy, it is arrhythmogenic. These dilated chambers, they throw arrhythmias, and because of arrhythmias, these patients, they present with palpitations. So the fatigue, dyspnea, chest pain and palpitations, these are the very, very important clinical manifestations. Then how do you treat this Keshan's disease? The treatment involves the medication and as well as the lifestyle modifications. So these individuals, they have to consume the healthy diet, which should be rich in the selenium. And these patients, they have to do the regular exercise, right? And avoidance of smoking, right? No smoking, and as well as no alcohol. So avoidance of smoking and alcohol, that is a very, very important part of the lifestyle modification. So that is about the selenium deficiency. The next important is the calcium deficiency. Now, what is this calcium? Calcium is a very, very important mineral which is required for the excitation contraction coupling. Right, which is required for the excitation contraction coupling. Now, whenever there is calcium deficiency, that will lead to chronic heart failure. Right, that will lead to chronic heart failure. Now, this chronic heart failure, it will respond over days or weeks to vigorous calcium supplementation. So that is about the calcium deficiency, and this will also lead to the development of dilated cardiomyopathy because there is decrease in the excitation contraction. Now coming to the endocrine disorders causing dilated cardiomyopathy. What is that? Very important is the diabetes mellitus. Now these patients with diabetes mellitus, they develop what is called epicardial coronary artery disease. And because of this epicardial coronary artery disease, they develop the heart failure. So basically, diabetes mellitus is a very, very important risk factor for the development of atherosclerosis, and that can cause epicardial coronary artery disease, and that will make the individual to develop the heart failure, right? And along with diabetes, what could be the accompanying risk factors for the development of the heart failure? The accompanying risk factors, they include the hypertension and as well as the renal dysfunction. Now, what type of heart failure that can be seen in patients with the diabetes mellitus is, it is heart failure with preserved ejection fraction, right? Where there will be diastolic dysfunction, right? Now, the another important point is how it can make the individual to develop cardiomyopathy. See, cardiomyopathy, it may result from, right? So cardiomyopathy, it may result from the insulin resistance, and as well as there will be increase in the AGE. What is this AGE stands for? AGE stands for advanced glycated end products. So, because of insulin resistance and as well as increased AGE, that is advanced glycosylation end products, that will make the individual to develop cardiomyopathy. So here, in this cardiomyopathy, there will be both systolic and as well as the diastolic dysfunction. Right? Both there will be systolic and diastolic dysfunction. Next is these patients with the diabetes mellitus, they also develop scattered focal ischemia within the myocardium. Now, why is this scattered focal ischemia? That is because of the distal coronary artery tapering. So, because of distal coronary artery tapering in dilated cardiomyopathy, there will be development of scattered focal ischemia. And because of this distal coronary artery tapering, what will happen to your microvascular perfusion? Microvascular perfusion will be reduced. And that is what is making the individual to develop the focal ischemia. There will be no proximal part of the coronary artery will be absolutely normal. So, proximal focal stenosis will not be there. It is the distal coronary artery tapering that will be there in patients with the diabetes mellitus. So, please remember these three important changes. There will be development of epicardial coronary artery disease causing heart failure. Because of insulin resistance and because of advanced glycosylation end products, there is development of cardiomyopathy. And because of distal coronary artery tapering, there is a scattered focal ischemia. Then, another very important risk factor that can make the individual to develop dilated cardiomyopathy is the obesity. So, the presence of or the development of cardiomyopathy in case of obesity is generally well accepted. Now, in what way the obesity will cause dilated cardiomyopathy? See, obesity alone, it is associated with impaired excretion of the fluid volume. Right? Why there is impaired excretion of the fluid volume in obesity? I will explain to you. Right? So, because of this impaired excretion of the fluid volume, there will be increased wall stress. Right? There will be increased wall stress, and there will be also secondary adaptive, right? Secondary adaptive neurohormonal responses. This is what will make the individual to develop the dilated cardiomyopathy. Now, the point is why there is impaired excretion of the fluid volume in patients with obesity. Now, the fluid retention, it is aggravated, number one, by fluid intake by the individual, because like the body surface area or the body mass is more, so he will be requiring more and more water. So, one point is because of the increased fluid intake. Another very important point is this adipocytes or the adipose tissue, what it will do is it will cause rapid clearance of the natriuretic peptide. So, we have brain natriuretic peptide which is released from ventricles and atrial natriuretic peptide which is released from the atria. So, because of excessive release of BNP and as well as the ANP, there can be natriuresis. So, natriuresis, what it will do, along with sodium, water is also taken out. But what happens in case of the obesity is this adipose tissue, it will cause the rapid clearance of the natriuretic peptide. So once these natriuretic peptides are cleared off, the natriuresis does not occur, and thereby the fluid will retain within the body, and that will cause the increase in wall stress and will over the ventricles, and that will make the individual to develop dilated cardiomyopathy. Now, how can you achieve the reduction of the symptoms in case of obesity? One of the very, very important measure is effective weight reduction. So, if the individual can achieve the effective weight reduction, that will improve the ejection fraction, right? That will improve the ejection fraction, and that will also improve the clinical outcome in the patient. Now, the another form of treatment for obesity is the bariatric surgery. So, even with bariatric surgery, like what happens, the stomach size will be reduced. So, the consumption of the food by the individual will be reduced. So, there will be weight loss, and thereby also there can be improvement in the cardiac function. There can be improvement in the ejection fraction. But only point is, whenever you are doing a bariatric surgery, there can be post-operative malabsorption of nutrients. Now, what is the very, very important nutritional deficiencies that can increase the risk in case of dilated cardiomyopathy is, so malabsorption of calcium and malabsorption of the phosphate. because of the bariatric surgery, that is very much deleterious for patients with the cardiomyopathy, right? So this is about the obesity. So obesity, please remember, because of impaired excretion of the fluid volume, there can be increased wall stress on the ventricles, and that can precipitate the development of cardiomyopathy. And in obesity, why there will be impaired excretion of the fluid volume? That is due to rapid clearance of the natriuretic peptide, and the effective weight reduction can improve the ejection fraction within the individual, and even bariatric surgery will also improve the cardiac function, and thereby the symptomatology can be reduced. But only thing is, there can be post-operative malabsorption and nutritional deficiencies of the calcium and as well as the phosphate. Okay, so this is about the story of the obesity causing the dilated cardiomyopathy. Now then, so what all we have discussed now is, we have discussed the metabolic causes for dilated cardiomyopathy. Now let me tell you the familial causes for the development of dilated cardiomyopathy. That means these are the ones which are inherited. So the familial causes, mainly they are muscular dystrophies, like you take the Duchenne's muscular dystrophy, and then like hemochromatosis, then skeletal and as well as the cardiac myopathy, and then the mitochondrial myopathies. So these are the familial causes for dilated cardiomyopathy. Now let me take up one by one. Now this familial causes for dilated cardiomyopathy, what is the frequency with which the individual can develop dilated cardiomyopathy? So the familial causes, they contribute to more than or equal to 30% causes for the development of the familial dilated cardiomyopathy. Now within the familial dilated cardiomyopathy, what is the very important protein which is being defective for the development of dilated cardiomyopathy is the titin, right? So that is, the mutation in the titin is what is responsible for the development of the dilated cardiomyopathy. Now what exactly is this particular titin? So titin, let me tell you, it is a giant sarcomeric protein. Right, it is a giant sarcomeric protein. Now this giant sarcomeric protein, that is titin, that is the most common cause, right? The mutation in this particular titin is the most common cause, that means most common familial cause for the development of dilated cardiomyopathy, right? And this titin mutation, it is responsible for almost 25% of causes of the familial causes for dilated cardiomyopathy. And remember, in those individuals or in males who have titin mutation, like you take, they develop the dilated cardiomyopathy much earlier than those females without titin mutation. Okay, so those individuals with titin mutation, okay, so they develop early dilated cardiomyopathy then compared to the individuals without the titin mutation. So this is about the story of your titin, right, which is a large sarcomeric protein. Then the next important is the muscular dystrophy. We have two important forms of muscular dystrophies. One is Duchenne's, the other one is the Becker's muscular dystrophy. Both of these will make the individual to develop the dilated cardiomyopathy. So these muscular dystrophies, they not only have the cardiac manifestations, they also develop extra cardiac manifestations, right? So what are those extra cardiac manifestations? That will be in the form of the skeletal myopathies. And which particular muscles are defective is, it is mainly the proximal muscles which are more defective than compared to that of the distal muscles. Okay, now this Duchenne's muscular dystrophy and as well as the Becker's muscular dystrophy, the gene which is being defective is dystrophin gene is being defective for the development of this Duchenne's or the Becker's muscular dystrophy, and it is an X-linked inherited disorder, right? It is an X-linked inherited disorder, and this dystrophin, the gene which is required for the synthesis of this dystrophin protein is the dystrophin gene, and this dystrophin protein, it is present within the sarcolemma. right? This dystrophin gene, it is present within the sarcolemmal membrane. And in these patients, the Duchenne's and as well as the Becker's muscular dystrophy, what would be the cause of death? The cause of death in these individuals will be the respiratory failure, and subsequently, even due to the development of the congestive cardiac failure, the mortality will be there. Okay, so that is about muscular dystrophies causing the dilated cardiomyopathy. So one is your titin gene mutation, the other one is the muscular dystrophies, that is your Duchenne's muscular dystrophy and as well as Becker's muscular dystrophy. The other one is we have a nuclear membrane protein which is called as lamin, right? Nuclear membrane lamin protein. So this nuclear membrane lamin protein mutation, that is responsible for 5% causes of the dilated cardiomyopathy, whereas titin gene mutation was responsible for almost 25% of causes for dilated cardiomyopathy, whereas your lamin protein mutation is responsible for 5% causes of the dilated cardiomyopathy. And these patients, what is the very important history is, these patients, they have either family history of the arrhythmias, or the patient himself, they will have the history of the arrhythmias or the conduction abnormalities. And the arrhythmias, like what will be the clinical manifestations? That will be in the form of the palpitations, right? That will be in the form of palpitations. Now these patients, like they develop a form of dilated cardiomyopathy where they have arrhythmogenic mutation, right? Where they have arrhythmogenic mutation. Now this arrhythmogenic mutation is what is responsible for the development of sudden cardiac death in patients with the lamin protein mutation. So that is the reason why these are the ideal candidates for the implantable cardioverter defibrillator. So by placing the ICD, there can be prevention of there can be prevention of sudden cardiac death, right? So that is the advantage of placing the implantable cardioverter defibrillator. So that is about your nuclear membrane lamin protein mutation. So they constitute 5% of causes of dilated cardiomyopathy, right? And these patients with dilated cardiomyopathy, they have arrhythmogenic mutation, and the arrhythmias, these individuals, they have the family history or the patient himself have the history of arrhythmias where the patient will complain of palpitations, and they are at increased risk of sudden cardiac death. So they are the ideal candidates for the ICD. Next important etiology for the dilated cardiomyopathy is the left ventricular non-compaction. So this left ventricular non-compaction is a condition of unknown prevalence that is increasingly suspected with the refinement of the imaging techniques. But what exactly happens here? What is the definition or the diagnostic criteria for LV non-compaction? So here you take the apex of the left ventricle or exactly distal to the papillary muscles, right? Exactly distal to the papillary muscles, there is presence of multiple trabeculations within the left ventricle. Right, there is presence of multiple trabeculations which are present within the left ventricle, and these trabeculations, they give the spongy appearance of the apex, right? They give the spongy appearance of the apex. So that is what is the abnormality in case of left ventricular non-compaction. So the normal muscle, whatever is there, is replaced by the multiple trabeculations. Why does it occur? That is mainly because of the gene mutations. So non-compaction has been associated with multiple genetic variations, right? So these multiple genetic variations are present within the sarcomere, and the gene that is being defective is TAZ gene, right? What is this TAZ gene? That is the one which will encode for tafazin. Right, that will encode for tafazin. So that is about the genetic mutation which is responsible for the development of left ventricular non-compaction. Now, in these individuals, there are the three important cardinal features. These three important cardinal features are: number one, the ventricular arrhythmias, that is VT or VF. Number two, embolic events, right? And number three, the development of the heart failure. Right, number three, the development of the heart failure. So the heart failure whichever is developing, that is mainly because of the defect within the left ventricular apex. Right, what is happening there? The normal myocardium is being replaced by the trabeculations. So thereby the LV apex is spongy and there is the systolic dysfunction which is happening within the apex. Now, how will you diagnose this LV non-compaction? See, this LV non-compaction, it is the diagnosis is made incidentally, like you have done 2D echo as a routine analysis. The 2D echo is showing the trabeculations, right? Or it is being diagnosed in patients previously diagnosed with the cardiomyopathy, right? So the diagnosis, it is mainly by your 2D echo. So, like, what is that you will see within the 2D echo? You will observe that the left ventricular apex, the endocardium is replaced by trabeculations and there is non-compaction. But this non-compaction, it may disappear gradually, but in early stages of the disease, you have that non-compaction where you have that spongy appearance. Okay, so 2D echo is one of the methodology by which you can diagnose LV non-compaction. Coming to the treatment, see, treatment is similar to that of your heart failure, and these patients, they are at increased risk of embolic events. So that is the reason why the anticoagulations in the form of low molecular weight heparin or the newer oral anticoagulants can be given. See, the warfarin is one of the oral anticoagulants. The other newer oral anticoagulants are dabigatran, apixaban, endoxaban, rivaroxaban. So these are the other newer oral anticoagulants. And even these patients, they are at increased risk of VT and VF causing sudden cardiac death. So these are the ideal candidates in whom you need to place an ICD. Okay, so implantable cardioverter defibrillator is the one which will prevent the sudden cardiac death within the individual. Along with that, you also need to supplement the neurohormonal antagonists. What are those neurohormonal antagonists? That includes the beta blockers. Next is the AC inhibitors, or the angiotensin receptor blockers can be given, and the other group of drugs are the aldosterone antagonists. So these are the group of drugs that we give for the left ventricular non-compaction. So please remember, left ventricular non-compaction is one clinical condition where there is multiple trabeculations within the left ventricle distal to the papillary muscle, and that is giving you a clear-cut spongy appearance at the apex. And it is mainly due to genetic mutation, and the gene which is being mutated is TAZ gene. That will be encoding for the tafazin. And the three cardinal features are VT or VF, then the embolic events, and then there will be also development of the heart failure, and that is mainly the systolic dysfunction. And the diagnosis is mainly by your 2D echo, and the treatment is you need to give anticoagulations, neurohormonal antagonist, and then placement of implantable cardioverter defibrillator that will prevent the arrhythmias. Next important storage disorder, right? The next important disorder that can cause the dilated cardiomyopathy is the Fabry's disease. So Fabry's disease, it is a storage disorder where there is an enzymatic deficiency causing this Fabry's disease. Now, what is that enzyme which is being deficient? That is alpha galactosidase A deficiency. Alpha galactosidase A deficiency will be responsible for the development of Fabry's. Now, this inheritance, if you see, it is an X-linked disorder, right? It is an X-linked disorder. Now, why there will be this enzymatic deficiency? That is due to mutation of the gene or mutation of GLA, right? What does this GLA stands for? Galactosidase alpha gene. right? Mutation of the gene GLA. GLA stands for galactosidase alpha gene. That particular genetic deficiency is, or gene mutation is what is responsible for alpha galactosidase A enzyme deficiency. Now the inheritance is, it's an X-linked disorder, and usually if it is an X-linked disorder, the females are the carriers, but here even the carrier females, they develop the clinical disease, right? They develop the clinical disease. Now in these individuals there is glycolipid accumulation, and this glycolipid accumulation, it occurs within the heart. Not only in the heart, the other tissues which are affected is the skin, then the peripheral nerve, next is the kidney. So the glycolipid accumulation in case of Fabry's disease, it occurs in all these organs. Now when you do an electron microscopy of, you do an endomyocardial biopsy, right? So this endomyocardial biopsy, you observe under the electron microscopy, that will show the presence of the vesicles, right? That will show the presence of vesicles containing concentric or lamellar figures. So vesicles are the one what you see in case of the endomyocardial biopsy. Then that is the how you can diagnose. The other methodology of the diagnosis is, you need to check for the enzyme activity. So alpha galactosidase A deficiency will be there. So enzyme activity is reduced, right? And the next important is the gene analysis, that is GLA sequencing, right? So it is mainly galactosidase A gene mutation is what is responsible for the development of Fabry's. So GLA sequencing is another very important method by which you can diagnose this Fabry's disease. Then how do you treat these patients? Number one, that is your enzyme replacement, that is alpha galactosidase A enzyme you replace. So that will improve the cardiac function and that will improve the cardiac symptomatology. Next important is the oral chaperone therapy. Now what is this oral chaperones? Before that, let me show you the endomyocardial biopsy. So this is the endomyocardial biopsy picture of the Fabry's. So this is the electron microscopic picture where you can see the ventricular, where you can have the concentric lamellar inclusions of sphingolipid accumulation as a result of deficiency of the lysosomal enzyme alpha galactosidase A. So these are the accumulations, right? So these are the accumulations that you will be able to see within the Fabry's disease, right? Now coming to the oral chaperone therapy. Now this oral chaperone therapy, what is the example? That is migalastat, right? So this migalastat, what it will do? It will stabilize the mutant form of the gene, right? It will stabilize the mutant galactosidase A gene, and this will also increase the enzyme activity, that is alpha galactosidase A enzyme activity will be increased, right? It will increase the enzyme activity. Which one? The migalastat. This is how you can see the improvement in case of the Fabry's disease, right? Then subsequently you need to know the glycogen storage disorders causing dilated cardiomyopathy. So it is mainly glycogen storage disorder type 3, which is nothing but the Cory's disease is also the one which is responsible for the development of the dilated cardiomyopathy. So glycogen storage diseases, they lead to accumulation of lysosomal storage products and intracellular glycogen accumulation. So in these individuals, there is intracellular glycogen accumulation. So this glycogen, it is nothing but the storage form of the glucose. So intracellular glycogen accumulation. That is what will happen in case of glycogen storage disease 3, which is nothing but your Core's disease. Now, why does this occur? This also occurs because of defective enzyme. Right? This also occurs because of the defective enzyme. Now, the type of inheritance that if you see in case of glycogen storage disease 3 causing, which is occurring due to enzyme deficiency, it is either autosomal recessive or X-linked deficiency is there. Right? Now, in this, because of autosomal recessive or X-linked deficiency, the enzyme defect is there, because of which there is intracellular glycogen accumulation. Now, what are all the organs which are affected here? So, there is accumulation of glycosaminoglycans within the skeletal tissue, right? Accumulation of glycosaminoglycans within the nervous system, and accumulation of glycosaminoglycans even within the heart. Okay, so these are the structures which are defective in case of this glycogen storage disease type 3. Now, these patients, they are being diagnosed in the early stages itself. In the childhood itself, we can diagnose these glycogen storage diseases. How? Because they have the short stature. Right? Number 2, they have cognitive impairment. Right? They have frequent cognitive impairment. Okay. So, based on this, you can diagnose these individuals early in childhood, and these patients, they die before adulthood. Right? They die before adulthood. Okay. So, this is one of the glycogen storage disease which can make the individual to develop dilated cardiomyopathy. So, if you take the familial disorders, what all we have discussed now? Number 1, titin gene mutation, right? And number 2, muscular dystrophies, that is Duchenne's and as well as Becker's muscular dystrophy. Number 3, the nuclear membrane lamin protein gene defect is also the one which is responsible for dilated cardiomyopathy. Next is left ventricular non-compaction, that is because of the gene mutation, that is TAZ, that is tafazin is the defect in case of the left ventricular non-compaction. And next is the Fabry's, that is mainly because of alpha galactosidase A deficiency, that is due to gene defect GLA, that is galactosidase alpha gene is being defective. And next is glycogen storage disease type 3 is also the one which can make the individual to develop dilated cardiomyopathy. Now, apart from these, we have 2 monogenic metabolic cardiomyopathies that can cause dilated cardiomyopathy. Now, what are those? Number 1, gamma 2 subunit of AMP, right? What is this AMP? That is adenosine monophosphate. So, gamma 2 subunit of adenosine monophosphate activated protein kinase. So, this gene mutation will be responsible for the development of dilated cardiomyopathy. Not only dilated cardiomyopathy, so what exactly is this? This gamma 2 subunit of adenosine monophosphate activated protein kinase, what is actually it is required for? This is required for the protein, this is required for the glucose metabolism. Now, because of this defect, the individual can have dilated cardiomyopathy, the individual can develop AV block, and the individual will also develop premature ventricular contractions. So, this is one of the monogenic gene mutation, that is gamma 2 regulatory subunit of adenosine monophosphate, which is required for glucose metabolism, can cause dilated cardiomyopathy, AV block and premature ventricular contraction. And another important defect which can cause dilated cardiomyopathy is LAMP2. Okay, so this is also an X-linked disorder, right? What is this LAMP2? So several defects have been reported in X-linked lysosomal associated membrane protein. So, defect in this lysosomal associated membrane protein, this particular defect, it is inherited maternally. Right? It is inherited maternally. Right? And the structures which are affected in LAMP2 mutation is, one is the heart which is being defective. Apart from the heart, the other structures which are being defective is, there is development of skeletal myopathy, there can be development of mental retardation, and there can be development of the hepatic dysfunction. So this combination, we call it as a disease called Denon's disease. So Denon's disease is due to what? It is due to defect in the LAMP2 gene mutation. Okay, right. So these are the two monogenic metabolic cardiomyopathies, right? And these patients, they develop the end-stage heart failure with reduced ejection fraction. They develop end-stage heart failure with reduced ejection fraction. So now in this LAMP2, when you do an electron microscopy in case of LAMP2 will show you that there is enlarged myocytes, right? Or there will be enlarged multiple intracellular vacuoles. And this enlarged multiple intracellular vacuoles, that is what makes the myocyte enlarged and makes the individual to develop dilated cardiomyopathy. So this is about your two monogenic mutations. So basically these two will make the individual to land up in end stage heart failure with, right, end stage heart failure with reduced ejection fraction. Okay, right. Next is the another important form of dilated cardiomyopathy is called peripartum cardiomyopathy. So this is usually seen in pregnant females, and this is the disorder which occurs or which develops in the last trimester of pregnancy, right, which develops in last trimester of pregnancy, or this develops within 6 months after the delivery of the baby, right, or within 6 months of delivery. Okay, very important criteria for peripartum cardiomyopathy is that there should not be, or there should be absence of demonstrable cause for the development of dilated cardiomyopathy. In the sense, the individual should not be a diabetic, the individual should not be having any coronary artery disease, the individual should not be having any genetic mutation, the individual should not be having any hypertension, or the pregnant female should not be having any nutritional deficiency. So in the absence of demonstrable cause, if there is development of dilated cardiomyopathy during last trimester of pregnancy or within 6 months of delivery, then we call it as peripartum cardiomyopathy. Now, what is the hypothesis is, it is vasculohormonal hypothesis. So in this vasculohormonal hypothesis, right, there are two important events which have been hypothesized for the development of dilated cardiomyopathy. So what are those two important events is, number one, the first event, one is genetic. And what is that genetic event is, the genetic event, it includes reduction in, right, reduction in STAT3 transcription factor. Right, reduction in STAT3 transcription factor. Now, because of reduction in STAT3 transcription factor, that will lead to cleavage of prolactin fragments. And this cleavage of prolactin fragments, it is caused by cathepsin D. Right? So, reduction of STAT3 transcription factor results in the cleavage of prolactin from pituitary by the cathepsin D. Now, because of the cleavage of the prolactin fragments, what is being formed? There is formation of 16 kilodalton fragments, right? There is formation of 16 kilodalton fragments, and this 16 kilodalton fragments increases microRNA 146A, right? Will increase microRNA 146A substance, and that will cause myocardial apoptosis. And this myocardial apoptosis which has been developed, that is what is responsible for the development of dilated cardiomyopathy. So this is one event. So what is happening here? There is decrease in STAT3 transcription factor, and that will cause the cleavage of the pituitary prolactin by cathepsin D, and the cleavage product, that is 16 kilodalton fragment, is being formed, and that will increase mRNA 146A, which is responsible for the myocardial apoptosis. Now, what is the second event? Right? What is the second event? The second event, or that is the factor which is released from the placenta, right? So second is from the placenta. Now what is that factor which is released from the placenta? Is soluble tyrosine kinase. Now this soluble tyrosine kinase, what it does? It blocks vascular endothelial growth factor. Okay, so the second important factor is the one which is released from the placenta, which is soluble tyrosine kinase, that blocks the vascular endothelial growth factor. Now this vascular endothelial growth factor is the one which is responsible for the development of peripartum cardiomyopathy. So these are the two important vasculo-hormonal hypotheses which have been predicted for the development of dilated cardiomyopathy. And the risk factors, if you see, this dilated cardiomyopathy is seen in multiparous females. See, in multiparous females, like what is happening? There is fluid overload with every pregnancy, and the heart, when it is taking load, excessive fluid overload in pregnancy multiple times, that can predispose the individual to develop dilated cardiomyopathy. And age of the individuals more than 30 years. So, right, elderly multiparous female, they are at increased risk of development of peripartum cardiomyopathy. The other important risk factor is the hypertension and the development of preeclampsia. Okay, so these are the risk factors for the development of peripartum cardiomyopathy. And what is the very, very important criteria that is required? There should be absence of any demonstrable cause for the development of dilated cardiomyopathy, right? And next important criteria is there should not be pre-existing cardiac disease. Right? There should not be any pre-existing cardiac disease making the individual to develop peripartum cardiomyopathy. Now, how do you treat these patients? That is mainly by beta blockers, right? And the beta blockers that is very much preferable is the sotalol. Okay, and this particular sotalol, it is acceptable for both ventricular tachycardia or ventricular fibrillation, and it is also acceptable for atrial fibrillation or atrial flutter. Okay, so if other beta blockers are ineffective, the preferable beta blocker is the sotalol, right? And these patients, they develop heart failure with reduced ejection fraction. So the diuretics should be given, that is mainly to reduce the pulmonary edema. Hydralazine should be given, that is mainly to reduce the afterload on the heart, right? And even nitrates, they reduce both preload and as well as the afterload on the heart. See, hydralazine, how it will reduce the afterload on the heart? So this hydralazine is an arteriolar vasodilator, and thereby it can reduce the afterload on the heart. And if the individual is refractory to medical management, then the option which is effective is the ECMO, that is extracorporeal membrane oxygenation. So in severe cases, the ECMO, it is life-saving in these patients with the peripartum cardiomyopathy. Now, what did we discuss in case of vascular hormonal hypothesis? It is the prolactin which is being released is what is responsible. The fragments which are being released from the prolactin is what is responsible for the development of peripartum cardiomyopathy. So, you need to give bromocriptine. So, bromocriptine is what? It is a prolactin release inhibitor. Right? It is a prolactin release inhibitor. So, this is considered to be beneficial in patients with peripartum cardiomyopathy, right? So, it has been shown to reduce the morbidity and as well as, right, it has been shown to reduce morbidity and as well as mortality in patients with the peripartum cardiomyopathy, right? Next, now what about the subsequent pregnancies? See, there is very high chance of recurrence. But when there is high chance of recurrence, remember the recurrences in subsequent pregnancies are very common. So that is the reason why the subsequent pregnancy, right, subsequent pregnancy, it should be avoided. Okay. When it should be avoided? If suppose, if the ejection fraction of the individual, if it is less than 55% and patient conceived again, there is high chance of recurrence. So that is the reason why until the ejection fraction has become normalized, the individual should avoid pregnancies. Okay, that is very, very important point. Next, what about the criteria we have discussed? The very important criteria is there should be ejection fraction that should be reduced. It should be less than 40%. There should be a documented systolic dysfunction. And other very, very important criteria for peripartum cardiomyopathy is there should be no pre-existing cardiac disease. That is what we have discussed previously also. Right? So this is the criteria for peripartum cardiomyopathy. So this finishes the etiologies causing dilated cardiomyopathy. So we have discussed the metabolic causes, we have discussed the infectious pathologies, then we have discussed drugs and toxins in the section of drugs and toxins causing myocarditis, then the hemochromatosis, familial disorders causing dilated cardiomyopathy, endocrine disorders causing cardiomyopathy, obesity causing dilated cardiomyopathy, all that we have discussed in detail. Now, we have few more forms of dilated cardiomyopathy, that is arrhythmogenic right ventricular dysplasia. Actually, it is not dilated cardiomyopathy, but the right ventricular myocardium, it becomes thin walled and it is dilated. And the other one is Takotsubo cardiomyopathy. Even that also is not a proper dilated cardiomyopathy, but the LV apex, it is dilated in case of Takotsubo cardiomyopathy, right? So these are all the various etiologies that will be causing dilated cardiomyopathy. So overall, in all the cases of dilated cardiomyopathy, what will be the clinical features? So these individuals, they will have the features of right heart failure and as well as the left heart failure. So right heart failure features include raised JVP, then there will be tender hepatomegaly, and these patients, they also develop edema, that is pedal edema or peripheral edema. So they develop portal hypertension, and secondary to portal hypertension, they also develop ascites, and next they also develop splenomegaly, gastrointestinal wall edema causing vomiting, and they also have nocturia and weight gain. And because of left heart failure, there will be decrease in cardiac output. So these patients, they have fatigue, and there can be backflow of the fluid into the lungs causing pulmonary edema. Right, backflow of the fluid into the lungs causing pulmonary edema, and because of pulmonary edema, these patients, they develop dyspnea. Right, these patients, they develop dyspnea, and these individuals, they also can develop sudden cardiac death. Now, what could be the cause for sudden cardiac death? The cause for sudden cardiac death, it is the arrhythmias. Arrhythmias, they are considered as the cause for sudden cardiac death. And how are the chambers? They are like dilated chambers, and there is systolic dysfunction or there is contractile dysfunction. So because of the systolic dysfunction, there can be stasis of blood within the dilated chambers. And the blood which has undergone stasis, there can be thrombus formation within the dilated chambers. And this thrombus which is formed within the dilated chambers will shower the emboli. So there can be thromboembolic events. There can be thromboembolic events. So this is about the clinical features of the dilated cardiomyopathy. And if you take the signs in dilated cardiomyopathy, because there is systolic dysfunction, so decrease in systolic blood pressure. So what will happen to the pulse pressure? The pulse pressure, it will be the narrow pulse pressure. And what will happen to the JVP? The JVP is elevated because of the right heart failure. And if you observe, there will be cardiomegaly. And these patients, they have all the signs of the heart failure. Right? So what all will be the signs of the heart failure? These signs of the heart failure, they have the triple rhythm, or they can also have the quadruple rhythm as well. And within the lungs, there will be bilateral basal crepitations. And why is that due to? That is due to the pulmonary edema. And because of the dilatation of chambers, there can be dilatation of tricuspid and as well as the mitral valve annulus. And thereby, these patients, they also have functional MR and as well as the functional TR. So these are the signs of dilated cardiomyopathy. Next, let me discuss now in detail about the investigations in patients with the dilated cardiomyopathy. So first and foremost, the chest X-ray. So the chest X-ray, it will show the presence of the cardiomegaly. And what is the criteria for cardiomegaly in adults on the chest X-ray is the cardiothoracic ratio, right? It should be more than 0.5 to call it as cardiomegaly on the chest X-ray. And within the chest X-ray, these patients, whenever they develop heart failure with reduced ejection fraction, there can be development of pulmonary edema. So there can be also pulmonary, or there will be pulmonary congestion that can develop within the lungs, right? And this pulmonary congestion, it is in the form of interstitial or alveolar edema, right? It is in the form of interstitial or alveolar edema. So that is what you will observe within the chest X-ray. Then next is the ECG. See, ECG, you will have a non-specific STT changes, right? There will be non-specific STT changes. There can be atrial fibrillation, or even there can be VT or the VF. So these are the ECG changes, and these patients, they will have left ventricular hypertrophy changes, but these changes that you will see within the ECG are the changes of the fluid overload. So if there is fluid overload causing left ventricular hypertrophy, what will be the ECG changes? That includes the exaggerated or deep septal Q waves, right? That will be more prominent in the ECG. Very, very important first line investigation for the diagnosis of dilated cardiomyopathy is the 2D echo. So what all you will observe? Number one, you will observe the presence of the dilated chambers. Okay. So almost all the chambers, they are dilated. That is one important thing. Next, you will also notice both LV and as well as RV systolic dysfunction, right? And if there is thrombus formation, you will also notice the thrombus within the left ventricle or within the atria, and there can be development of pulmonary hypertension, and that can be measured by the two-dimensional echocardiography, right? And the other points are the functional MR and functional TR. So when you do a color flow Doppler, the color flow Doppler will show the functional MR and as well as, right, functional MR and as well as the functional TR. That is what the color flow Doppler will show. And continuous Doppler will estimate the pulmonary artery pressures. And intracavitary thrombus can be seen. Why there is thrombus formation? Because there is systolic dysfunction. There can be stasis of the blood resulting in the thrombus formation. The biomarkers BNP is elevated. Why? Because of the stretching of the ventricular myocardium, the BNP is elevated, and that will decide not only the diagnostic factor for the development of heart failure, it is also the prognostic factor for the development of the heart failure. So depending upon the treatment, the levels of your BNP level, the BNP levels will be reduced. Okay. Next is the angiography. So angiography is being done mainly to exclude the coronary artery disease, right? Next important investigation is the exercise or the pharmacological stress myocardial perfusion. So the exercise or pharmacological stress myocardial perfusion, this will uncover, right? This will uncover the underlying coronary artery disease, right? Next important is the radionuclide ventriculography. See, we have the two-dimensional echocardiography, which is a method, which is a diagnostic method by which you can check the ejection fraction. And another non-invasive measure for estimating the ejection fraction of both right ventricle and left ventricle is the radionuclide ventriculography. And next thing is the cardiac MRI. So cardiac MRI, in what way it is useful is, it is helpful in the inflammatory infiltration process. So, right, inflammatory infiltrations that can be checked by the cardiac MRI. So this inflammatory infiltrations that includes sarcoidosis, right, that includes the hemochromatosis. Right, sarcoidosis and as well as the hemochromatosis. So this can be made out by the cardiac MRI, right? And this cardiac MRI can also help define the ischemic geology. Where exactly is the site of ischemia? That can be made out by the cardiac MRI. Okay, so wherever there is ischemia, there is late gadolinium enhancement which is being present. Okay, so late gadolinium enhancement consistent with myocardial scar that can be made out by the cardiac MRI. Next is the myocardial biopsy. This myocardial biopsy, right, so this is rarely useful in establishing the diagnosis of the etiology causing the dilated cardiomyopathy like hemochromatosis or sarcoidosis. We will be able to make out by doing the myocardial biopsy, but this is being done rarely. So these are all the investigations. So first line investigation will be your 2D echo, which will help in telling you the ventricular dimensions and as well as the ejection fractions. Next is the treatment in case of the dilated cardiomyopathy. So the drugs what you need to give is the drugs what we give in the treatment of the heart failure, that is the beta blocker should be given, but whenever you are giving these drugs you need to be cautious in maintenance of the blood pressure. Systolic blood pressure should be more than 90 millimeters of mercury whenever you are giving these beta blockers, and the beta blockers which are being preferable is the bisoprolol or metoprolol or carvedilol. So BMC, bisoprolol, metoprolol or carvedilol, these are preferred. But remember again, whenever you are giving beta blockers, you need to start with low dose and then you need to slowly step up the dose depending upon the tolerance of the individual. And the other drugs are the AC inhibitors, right, or angiotensin receptor blockers should be given. So these drugs, they prevent the cardiac remodeling and they will improve the ejection fraction and they will reduce the mortality in patients with the heart failure. Now, in spite of giving these drugs, if the patient is still symptomatic, then instead of these AC inhibitors or ARBs, what you need to do is you need to add the aldosterone antagonists, right? And these aldosterone antagonists, they include spironolactone and as well as eplerenone, but you need to be little cautious whenever you are giving spironolactone because the individual can develop tender gynecomastia. Then the other drug is the ARNI, that is angiotensin receptor blocker, that is valsartan, and NI stands for the neprilysin inhibitor, and this neprilysin inhibitor, it includes the sacubitril. Okay, so valsartan plus sacubitril should be supplemented if the patient is not responding to your ACE inhibitors or the ARBs alone, right? In the patient is symptomatic in spite of giving these beta blockers and as well as ACE inhibitors, then you need to add the aldosterone antagonist, and in place of the ACE inhibitors or ARBs, you need to give the ARNI. And the another important thing is what is the advantage of giving this ARNI? The advantage is it will improve the ejection fraction of the individual, and whenever you are giving this ARNI, you have to monitor the renal function test, that is you need to monitor the serum creatinine, and you also need to monitor the electrolytes such as potassium should be monitored, right? Next is the complications, like the treatment of the atrial fibrillation. So beta blockers, they have to be given, that is mainly to reduce the ventricular rate, and they will also improve the diastolic filling. That is the advantage of giving the beta blockers. So whenever the patient is in atrial fibrillation, please remember the rate control is very important then compared to that of the rhythm control, right? Then when will you give? Usually calcium channel blockers, they are avoided in case of the dilated cardiomyopathy, right? Except only when the beta blockers are absolutely contraindicated, where you cannot give, like in case of respiratory pathologies, there you need to give calcium channel blockers to control the ventricular rate. Otherwise, the calcium channel blockers, they are contraindicated in patients with the, or avoided in patients with the dilated cardiomyopathy, because they will further reduce the cardiac contractility and thereby reducing the ejection fraction. Okay. Next is the digoxin. Digoxin, it is considered as the second line drug in the treatment of the ventricular rate. Okay. This digoxin, what it can do, what is the advantage? It will reduce the hospitalization of the individual, and it will also control the ventricular rate. VR stands for ventricular rate. That means basically it will control the heart rate. Next is rhythm control. So rhythm control can be achieved by giving amiodarone, or the another important drug is disopyramide, right? The another important drug is disopyramide. So these are the drugs which will do the rhythm control. Next is the anticoagulation. So in order to prevent the thromboembolic stroke, you need to give low molecular weight heparin, or the warfarin should be given. Okay, low molecular weight heparin or warfarin should be given. But if there is no coexisting mitral stenosis, you can give newer oral anticoagulants. Newer oral anticoagulants are usually avoided if there is valvular pathologies. If there is no valvular pathologies, then the newer oral anticoagulants can be given. Like what are those? Dabigatran, endoxaban, rivaroxaban and apixaban. So these are the NOACs. If there is valvular pathologies, preferably to give low molecular weight heparin or the warfarin should be given. That is mainly to prevent the thromboembolic stroke. And the other drugs which are very important in dilated cardiomyopathy is the ivabradine. See, ivabradine should be given if there is sinus rhythm, and only when the heart rate is like more than 70, and where the beta blockers are avoided, there we give the ivabradine. So if the heart rate of the individual is more than 70 and the ejection fraction of the individual is less than 35%, where you are unable to give beta blockers, then you can give ivabradine. But the patient should be in a state of a chronic, stable heart failure. Okay, to give this ivabradine. Next is hydralazine, that will reduce the afterload on the heart by causing arteriolar vasodilatation, which will be helpful in preventing the cardiac congestion. Next is the sodium restriction should be done in case of the acute heart failure which develops secondary to the dilated cardiomyopathy. And in order to improve the oxygenation, or in order to improve the saturation, you need to connect the patient to continuous positive airway pressure. Okay, that will improve the LV function, and that will also improve the oxygenation within the individual. So this is about the medical management. And if the individual is refractory to medical management, then we have devices that we place in dilated cardiomyopathy. One is CRT, right? So CRT, it should be placed in patients with dilated cardiomyopathy, refractory to medical management, and the QRS complex, it should be more than 120 milliseconds, or there is dilated cardiomyopathy with left bundle branch block where the QRS complex more than 150 milliseconds, right? So these are the ideal candidates for placing the cardiac resynchronization therapy, right? And not only that, if there is functional MR, even that can also be reduced by placing cardiac resynchronization therapy, right? Next is the ICD. Now, who are the candidates in whom you need to place the implantable cardioverter defibrillator? So, in individuals who has developed coronary artery disease, that is myocardial infarction, and ejection fraction of the individual is less than 30% and almost 3 months over, right? Almost after 3 months of the development of myocardial infarction with ejection fraction still less than 30%, he is an ideal candidate to place an ICD, right? Why is that? Because these individuals, they are at increased risk of development of the arrhythmias, where they can have sudden cardiac death. So the ICD has to be placed in these individuals. So this is almost like class 1 indication. The other important device is the destination therapy, right? What is this destination therapy? So that includes the left ventricular assist device, right? Left ventricular assist device. So what exactly is this? It is a bridge transplantation therapy, right? It's a bridge transplantation therapy. So these left ventricular assist device, it acts as a bridge transplantation or a temporary measure until the cardiac function returns back, right? So this LVAD, it acts as the bridge between an individual and the cardiac transplantation, okay? Or the individual is unable to get a transplant, then you place the LVAD. So these are the devices that you need to put for dilated cardiomyopathy. So conclusion, if you see in case of dilated cardiomyopathy, it is the most common form of the cardiomyopathies. It is the condition which is characterized by heart failure with reduced ejection fraction. And there are multiple etiologies which will be causing dilated cardiomyopathy, starting all the way from the infectious or inflammatory conditions, which includes the infections, that is viral infections, and non-infective pathologies like sarcoidosis or giant cell myocarditis. Then subsequently the other etiologies like genetic causes are there, infiltrative pathologies are there, then the endocrine pathologies are there, the obesity, genetic mutations, all these they can contribute to the development of dilated cardiomyopathy, right? And in all of them, the clinical features, they include the features of both right and as well as left heart failure. They can present with sudden cardiac death. They can also develop thromboembolic manifestations, and the signs will be, there will be decreased systolic blood pressure, there will be narrow pulse pressure, quadruple rhythm can be there, and functional MR and functional TR will be there on examination. And first line investigation will be 2D echo. 2D echo will demonstrate the dilatation of all the cardiac chambers, reduced ejection fraction, functional MR and functional TR, and even if there is development of pulmonary hypertension, that can be demonstrated on the 2D echo. And the treatment, you need to treat similar to that of heart failure. The ideal drug is you need to give ARNI that can improve the ejection fraction within the individual. And if the individual is refractory to medical management, then the options that we have is the CRT, and post MI 3 months you can place ICD. If the ejection fraction is still less than 30%, then the bridge therapy will be the left ventricular assist device. So this completes the discussion of the very important topic, that is dilated cardiomyopathy. Thank you very much.